uh, by attending today here in person, you are eligible for CME. However, we do record this so that we can put it on our YouTube channel so that those that aren't able to participate with us today can still come and watch and learn and value, or come watch and learn. But we do appreciate you all being here and valuing your participation. So, thank you. Go ahead, Raina. Just a few helpful hints or tips for using Zoom. We're all pretty great at this, but we ask that you keep yourself muted until when you're not speaking. Remember to unmute. I'm sure we'll all be telling you, "Hey, you're still on mute." And obviously, these kind of conversations go way better when we can see your beautiful faces. So position that webcam effectively so we can see your face. And speak close to the microphone so we can hear you. A few of you, it looks like can't get on camera today, and that's fine. But we still encourage you to jump on in and participate. We also run the chat. So if during the presentation you have a question, feel free to put it in the chat, and at an appropriate moment, we'll chime that in. So go ahead. There's three dots on the screen, and you can find yourself also under participants. If you need to rename yourself, please do so. Put your name and or your organization. And perfect. And lastly, we ask just communicate clearly. So you can use the raise hand function, use that chat function, and you can chat everyone or other groups that are there. So. And finally, we really ask that you respect private health information. All of us, well, most of us here are practitioners, so I'm a clinician, so this is no new thing to you, but leave out names, locations, dates, employment, other kinds of identifiers. We do love hearing about patients and applying these principles, but obviously just want to make sure patients are protected. So with that, welcome. We're so excited you're here. And I would love it if everyone could go into the chat and go ahead and put your name. And for our fun icebreaker thing, put with your name an emoji that summarizes how you're feeling today. So go ahead. I'll give a moment here for you to all throw that in the chat. And Raina, go ahead and take us to the next slide while everyone's doing that. I do like to review here the ethos of this ECHO program is really obesity is a chronic and relapsing disease. And in our conversations that we're using today, please use person first language, the patient with obesity. And lastly, we want to make sure that this is a safe place to learn, share those experiences. Please ask questions. There is no dumb question thought, any of that. We want to make sure that everyone is leaving here better than we started. So please share and jump in when you see appropriate. So the next is our agenda. We're doing our welcome now. And then we're going to have our didactic presentation. There will be some polling and Q&A time there at the end of it. We have a case presentation today, and then we'll dive in and help see what we can come up with as recommendations that we can pass along to the clinician that submitted this. So, and finally, then we'll wrap up with closing. I do want to just we'll emphasize this at the end, but it's June, July. Our July program will be on July 11th. Normally we do this on the first Friday, but I think hopefully we're all enjoying some fireworks and parades. So we'll see you all on July 11th for next month. So with that, I want to hand it over to our presenter who's going to be talking about physical activity and fitness. Renee, this is your moment, and we're so glad you're here. So thank you.
Thanks everyone for having me. Hi, I'm Renee Rogers. I'm a senior scientist at the University of Kansas Medical Center, and I've been working as a practitioner, exercise physiologist by training, but have designed lifestyle interventions across my career for patients living with obesity. So it's like working on 20 years in this space now. I hate to say that. I think of the number every year. I'm like, oh no, it's getting a little bit higher, but have loved every moment of it. And I've had the pleasure of working on many of the large scale lifestyle interventions where we've come up with physical activity recommendations. And most recently have developed exercise programming for metabolic bariatric surgery and also heavily in the space of pharmacotherapy and physical activity right now. So I know this is a burning topic for so many of us when it comes to physical activity and body composition. So I'll try to touch on some of that today as well. But thank you for having me. And I do have a couple of disclosures on here, none of them really related to anything I'll be talking about or anything in, but just so that you know that from a transparent standpoint, what I do. And a couple of our learning objectives. So I approach things in a broad way. So really want to just remind you of some of the physical activity guidelines that are out there related to physical activity and obesity treatment. But in addition to that, what's new, I think, is what's really striking right now and how exciting this time is. My work is very focused, as I'll talk about, in the balance of not just the biological prescription for physical activity, but also the behavioral prescription and how we think about it from a patient first, person-centered perspective, which we'll chat about again today, and really try to close out as time permits with how we can have better conversations with our patients about how to engage in physical activity. So hopefully we can touch all of that quickly here. And as I mentioned, person-centered, not method-centered is truly my mantra when it comes to this. I believe this is the case in all obesity care, whether it's going through lifestyle, medical management, and hopefully all of you are on the same page with me. But my biggest pet peeve sometimes, and when I speak to clinicians, when it comes to lifestyle elements, especially physical activity, is we tend to throw that blanket recommendation on our patients. Well, the guidelines tell us this many minutes per week, so you need to get to the gym and start doing that. And I'm sure a lot of us are guilty of that. And it's not always our fault. And I think that's an important thing. That's how the guidelines are presented to us. They're never presented in a way of, now, how do we actually bring these to life for our patients? So I hope we can talk a little bit about that today and what we're doing. But this is if you've ever seen me present or see me in the future, you're probably going to see this slide again. But this is really how I approach my work and how I approach not only recent research, but our interventions for patients in practice are the human living with obesity sits in the center of everything that we do. And when we design exercise interventions, from the biological standpoint, we are really thinking about what's going to give them the best bang for their buck physiologically and for their health. Of course, that's why we're recommending this. That's why we recommend any of our medical management treatments. But on the flip side of it, we've got to respect and acknowledge the patient, their barriers, before we start to overlay recommendations. So it's constantly a seesaw. And in life is, for our patients, it changes, it ebbs and flows as maybe they start to manage weight, it changes. That's also going to change how our conversation might go. So I always say this is the fidelity adaptation paradigm. We really want to be true to what we think is going to make the best health impact on our patients, but we must respect the fact that each human is going to have to adapt to that differently. So this is what I call biobehavioral approach. So we take the biological, the weight and non-related weight-related outcomes that we care about, and we match that with what our patients' perspectives are of physical activity and healthy lifestyle engagement and what that means for them. And that's how we can recommend better physical activity targets. So the big question, and I think I've been asked this almost in every talk that I give, so I'm going to try to preempt it because of our short time today together, is what should our focus be when we are talking to patients about physical activity? And, for many years, right, when we were talking about lifestyle intervention alone, not necessarily medical management strategies, the focus was always on the weight, right? What's physical activity going to do to get the weight down or keep the weight lost off in maintenance, right? The big push right now is body composition, right? Which I love. I love that we're moving more into a body composition space. Is what does physical activity do in terms of, adiposity? We can look at our muscle parameters, but also all of it, not just skeletal muscle mass, but what about our cardiac tissue mass? What about our smooth muscle mass? And what about bone? What does it mean in this relationship? And we do know that there are benefits of physical activity in this. I will argue we have a lot to learn in the hypocaloric state, however, and with these very, very effective obesity management medications, what the true impact physical activity will have on body composition. We still have a lot to learn, which we'll get into. Again, at the end of the day, though, this is where I think our focus needs to remain is on the patient and their health and well-being. So is the way we talk about physical activity so guideline based? Is that our first mistake? Or is it because we're talking too much biology and we're not talking about relevant individual health benefit? So how can we match all these things? So throwing this out on the top, and hopefully as I talk to you, it'll get a little bit clearer. But I do want to point out to you that I have some QR codes throughout the presentation. So if you're one that likes to grab different papers and read them, especially because of the length of the talk today, I encourage you to grab these. I've tried to give you links to things that are pretty open access for the most part. But this is a paper that was led by my very good colleague, John Jakisik, and many of you may have heard, his work in terms of being probably the original physical activity researcher. I'm lucky enough to have him down the hall to work with on a daily basis. But John and I and Carolina Povian put this together because we wanted to remind people, especially in the physical activity space, of the unique pathways that our patients are taking. And again, I don't have to probably reiterate all of this to all of you, but I think much of the world still looks at it's either lifestyle, it's either pharmacotherapy, or it's metabolic bariatric surgery. And I think we all know that that's not really the case. And the top part of this figure is probably more what it really looks like, right? We may start one path, we take another path. We might recognize that a patient might need to lose some weight before they can really dive into physical activity. Maybe they need some rehabilitation or to look at some of their orthopedic conditions first before we jump in and dive down these pathways. It looks really good on paper, but all of us understand that this comprehensive care approach that I know, OMA is constantly, when we talk about those pillars, right, we're thinking about that comprehensive approach is not as easy as we want to say it is. Even though we know it's important, the pathways for our patients aren't always clear cut. And it is a shared decision between all of you as providers and your patients as well. So this paper does a really nice job in helping to think about how we can really think about physical activity maybe a little bit different in that relationship, but it also acknowledges that, yes, today we're talking about physical activity, but without behavioral mental health support and without the dietary counseling in combination, all these things aren't quite as effective, especially with our obesity management medications now. So I encourage you to take a look at this paper. It's a really nice piece. All right. This is the other one that I want you to grab. And this is a beautiful consensus statement that the American College of Sports Medicine just put out. John Jakisik led this effort as well with a bunch of amazing clinicians and colleagues out there. But this is the new way we are looking at physical activity. It is not just about how many calories can you burn by doing physical activity. If anything, from a behavioral perspective, we've learned that that's not helping our patients develop a healthy relationship with physical activity or a lifelong, long-term relationship with it. Now, if we are going down the path of lifestyle alone for an initial starting point or as a strategy, yes, energy expenditure may matter, it does matter in the relationship. But in essence, we're thinking about this much differently. We're talking about things like muscle quality and function, physical function, cardiorespiratory fitness, muscle strength, kinesthetic awareness, meaning our patients are losing weight. They don't know their body in space. I can't tell you how many of the patients I worked with post-metabolic bariatric surgery would say, I don't know my body. And now you're telling me to go exercise? Are you kidding? I don't feel coordinated. I don't feel comfortable, right? So how can we help promote that? How can we talk about balance, fall prevention, better mobility to help with joint pain, and different things along those lines? So it's a much more dynamic relationship. It's not just about how many calories you burn. So once again, I encourage you to grab this paper and have this as a nice tool in your tool. So let's get into this idea of balancing biology and behavior. And really thinking about both these worlds. So, and I will say this right off the top, I'm thinking about this from the perspective of how can we tailor our physical activity recommendations in collaboration with the medical management of obesity, not as this is going to be the solution, because we well know now, right, that we have more tools available and our patients often need more than eat less, move more, right? Okay, so From a lifestyle, as a reminder to all of you, and I'm sure most of you recognize this and know this, but from a lifestyle only perspective, if this is a pathway that you're working with your patients, as a reminder, yes, the focus is typically that eat less, move more, right? Trying to help them moderate the diet. Yes, diet quality is mixed in there. Yes, the physical activity piece is the move more. And what we know is that we can achieve modest weight loss in a matter of 6 to 12 months, likely maintain that through some of our highly intensive lifestyle interventions that incorporate strong behavior change strategy. We can get approximately 8 to 10% weight loss. Some people more, some people less. There is an enormous amount of variability around that. Our one caveat is that when we do translate this into commercial and clinical practice, these numbers look like more 5 to 7% because you don't have that same behavioral support typically around the programs. Yes, it's a hypocaloric diet, normally, reducing calories by 500 kcals a day, but we are looking at high dose physical activity, ramping patients up to 250 to 300 minutes per week. I'm sure you all know how difficult that is to maintain, sustain, and motivate for. We work extraordinarily hard in our lifestyle trials to pull it off, so we know in real world it's tough. But when we talk about medical management, specifically pharmacotherapy and metabolic bariatric surgery, I want to skip to the end, the bottom of the slide here, and really hit on, yes, we talk about this from a diet quality and a nutrient intake, right? Nutrient deficiency standpoint with our patients. But what's our physical activity prescription? We we don't really have one, right? There's not been any studies that have done that really demonstrate what we should be telling our patients. And I would argue in the metabolic bariatric surgery space, we've kind of taken what we just do with lifestyle alone and oftentimes have overlaid it onto patients. There hasn't been a lot of focus on body composition, muscle health, muscle quality, as much as likely should have been. There's no major formal guidelines around that. And now we're in this highly effective pharmacotherapy landscape and we're in the same boat. What should our new prescription be? And being someone that is the exercise geek on this call, I'll tell you, we haven't had the clinical trials to demonstrate what it should be. Some are ongoing, which I'm happy our group is doing some of that work. But we probably should have been doing this a long time ago in the metabolic bariatric surgery space, which we haven't done. So, what should the new focus be? What should we be putting our priority into? And I'm going to throw body weight off the table right now because, when you're getting anywhere from upwards to 15 to 30% weight loss between pharmacotherapy trajectories and metabolic bariatric surgery, we don't need any more weight loss through physical activity, nor would we expect there to be an additional additive effect. So let's let go of that, right? Our patients are already choosing that tool and pathway with you. Let's focus on these other elements. And, one might argue it's body composition, quantity, tissue quantity, which we'll talk about. It may be tissue health quality, which we'll really get into here. But again, on the right side of the screen, let's talk about quality of life for the patient. What about all those other independent effects of activity? And I think the biggest one is how do we help our patients develop a healthy relationship that's not just about energy expenditure? Because we know that's not a long-term strategy. So when we've really gotten into this space of thinking about the body composition to start, right, especially related to pharmacotherapies, Tom Wadden has put out this lovely paper early on where we really talk about the contributions of lifestyle in this new space and what we need to be thinking about. We recognize that our obesity management medications are doing a lot of positive things, all the green check marks, which you all know. There are concerns about the lean mass reduction, but I will pause and remind you all that we don't actually know the muscle mass loss contributions broadly with these medications just yet. And one thing that I want to remind you is when you see in the literature lean mass, do not immediately jump to the fact that that is referring to muscle mass. Now, muscle mass is a component of lean mass. It is not all of it. It may be 50% of it. It depends on the human, though. There's a ginormous amount of variability around that number. So one of the biggest things that's happening, I know you're all aware of it, you may have done this as well, is when you're talking to patients about these medications and why they need to be exercising, you may say, you need to be doing resistance training because you need to preserve your muscle mass. Well, we don't have that evidence yet. And we haven't even measured how much muscle is being lost per se We only know lean tissue estimates. So even with some of the stuff that's come out with our myostatin inhibitors, you may have heard about this week, and some of the new drugs in the pipeline, like phase 2 data came out this week in general, saying that, hey, we're preserving muscle mass, when the reality is they only measured lean mass. So we don't really know those numbers. But the bigger thing is we haven't measured whether or not exercise in the hypocaloric state will actually preserve or attenuate muscle mass loss. So this is a big take home. Hopefully we can really dive into and discuss later. So early on in this relationship, we published another paper in obesity that really hypothesized what we think physical activity may or may not do and how we can maybe think about this a little bit broadly. So this figure has a lot on it. And I'll start by saying that the white at the top, right, is what we know our obesity management medications, specifically our more contemporary semaglutide, tirzepatide, right, are doing right now in terms of adiposity reduction and how this is helping, across the board with health and well-being. The concern over lean mass is there in yellow, right? We know it's reducing our lean mass. I'm not saying muscle yet, I'm saying lean mass. When we look at the contribution of physical activity historically in a hypocaloric state, we recognize that patients are still going to lose lean mass. When there's large magnitude weight loss, some of that is going to remain lean tissue. Likely we don't need that tissue, right? It's not metabolically healthy tissue. But physical activity may or may not help to slow that loss or maybe not lose as much. I hate to say preserve. Preserve's a big word, and we don't have that evidence yet. But what we do know is what's in orange is that even with the loss of lean tissue, physical activity plays a critical role in function and quality of the tissue. And that is where that metabolic profile, that health benefits likely coming from across the board. Let's get into that a little bit more. So before we jump, let's be careful. The problem we have right now in this new space is we don't have enough studies with contemporary nutrient-stimulated hormone therapies or obesity management medications. We haven't really measured muscle well. And beyond measuring muscle well, we haven't measured the contribution of resistance and or aerobic exercise in changing, preventing, attenuating lean tissue or muscle tissue changes. But we are recommending it. The question is are we recommending it for the right reasons with the evidence? So if we dive a little bit deeper into muscle health resistance training, let's talk about this. And I want to bring you back in time to 1991. And you're like, you're just talking about contemporary meds. Why are you taking me back this far? Well, Joe Donnelly's work was in very low calorie diets early on and using exercise, and really good series of papers that came out of his Met trials in this area. And we like to use this as an example right now as we think and hypothesize the role of exercise, because this is similar to what our patients on these medications are experiencing, right? It's a very low calorie diet that they're inducing, right? The state that they're in. So just to anchor you to this slide, this trial per se had a diet only group from left to right. They had diet plus endurance training, diet plus resistance training, and then diet plus combined training. Now, baseline is what you're seeing in blue, and change after 90 days, 3 months is what you're seeing in green. So this first slide is fat mass. You can see that regardless of group, no significant difference with the addition of exercise, but all patients lost a significant amount of adiposity fat mass when in this state. This is lean mass. So even with the addition of resistance training, there was still a reduction in lean mass. And guess what? There was no difference between the groups. So it did not change the amount of lean mass that was lost in a very low calorie state. So is this the whole story? Now, this is the question of quantity versus quality. And the answer is no. Blatantly no. What we still were able to see, if you pay attention to the red arrows, is when patients doing resistance training were even losing lean mass after 3 months, they still were improving strength, a greater magnitude without combined training, more so just with resistance training alone, but strength and function significantly improved. Same thing goes for endurance training, cardiorespiratory fitness. If they were doing aerobic training, they were improving their endurance, fatigue, and cardiorespiratory fitness. So this is our hypothesis at this time is that it's more about the quality and the respiratory changes in the muscle. That may be what matters more than anything in this relationship. So, is it all about resistance training? That's really our big question. Is it about quantity or quality? I would argue probably quality. And what happens in the hypocaloric nutrient deficient state matters. This isn't just like a normal human going to the gym, adding lots of protein and pumping iron, it works out. We're in a metabolic state that's different. So, we need to acknowledge that. Okay, so here's another paper I encourage you to grab. We recently published this that talks about, some of the fun questions around this, that before we give our patients blanket recommendations, let's consider these nuances that still need to be studied. So how do we find the appropriate target? And I published some of this work in our ACSM's Health and Fitness Journal, more specific to educate fitness professionals about this new space. But I think some of this is pertinent for all of you in our last minute here. And really, the first piece of this is based on qualitative data interviews that I did with patients. So before I ever overlay an intervention, I love to hear from patients on their thoughts and perspectives. So we asked them, these are patients prescribed semaglutide or tirzepatide. We asked, how do you feel about exercise? What are you hearing? What are your thoughts? And what are your barriers for engaging? And in summary, there's a lot here on this slide. I'm sure you've heard all of these things before, but many patients report, and the box indicates the magnitude of how many people reported. Bigger box, more people talk about it. Discomfort's a big one, worried about how they look and feel going to a gym. So when you tell them you need to go to the gym and start resistance training, this is a huge barrier that comes up. Feeling like they aren't comfortable exercising in front of others. Telling us that they're very fatigued on these medications. They don't feel like they have the energy, but that may be a reason why they're interested in engaging in physical activity. Self-efficacy is huge, and stigma support is huge. They feel like they've been told they've been taking the easy way out by fitness professionals, which is horrible. Please pay attention to who you're referring your patients to, that they recognize obesity as a disease and they respect you as a clinician and your shared decision with your patient before they speak out of term. And then also they feel like from both their clinicians and exercise professionals that they're getting a lack of counseling due to their size, that they are working with professionals or they're being told, get some of that weight off before you start exercising. That's a big assumption that maybe we shouldn't make, right, for the human in front of us. But self-efficacy is big. They do feel as though they don't have the skills, even though they know it's important. They tell you it's important. They say it's important. They don't take action likely because of having negative past experiences, never being an exercise person, they would tell me, or they have safety concerns. Few of them mentioned that their providers had told them they were going to lose muscle and that scared them, but didn't scare them enough to take action. So it's an important thing for us to consider. And I will tell you that of the patients that reported high levels of fatigue on the medication and weakness or loss of strength, those are also the same patients that have lower levels of physical activity when we quantified it. So maybe there's a relationship there, and this could be a really cool side effect that we could be helping with. It's very relevant. So in summary, better conversations now. How do we have a better conversation? Maybe we should talk to our patients before we recommend a guideline. What are your previous experiences? What do you like and dislike when it comes to moving your body? What are your fears? How are your energy levels? And that can help you as providers referring for the person in front of you, not the service, rather than saying, just go to the gym, saying, hey, what do you like? Outdoors, there's a cool nature hiking program. Have you ever thought about doing something like that, right? So you're referring more for that human in front of you, and you're really targeting self-efficacy, understanding and taking the time for their previous experiences. Also, environmental considerations are big. Some people, it's not okay to just go outside and take a walk. Some people don't feel good in a gym. So really asking those questions will really take you a long way. So as we go forward, I remind you, comprehensive care teams, let's find the physical activity folks that are qualified to be on those teams and refer appropriately for the person, not the method. And instead of just talking about body composition and physiological benefits, let's move less away from the biology and let's talk about the health and the well-being of the human in front of you. But also, we got to acknowledge we don't have all the answers yet. Hopefully, we'll have more soon. Thanks, everyone.
Wow. Thank you. That was amazing. I kind of didn't want it to end. Um, so we do have the chat open, and for everyone here, we actually have a few poll questions we're going to put up. So, anyways, we hope you all participate. So I'll do the first one here. You'll see it pop up on your screen. More seconds here. Okay. Courtney, we will get to your question in just a moment. So I'm going to hit end poll and share the results here with everybody. Renee, do you want to walk us through this? Are you all seeing it? I hope.
Yeah, no, this is great. A little bit of a trick question, right? Because it comes down to that person in front of you. What I'm thrilled is that no one answered number one. Thank you for that. I'm glad to see that that came across because we need to know the guidelines. We need to understand these things, right? But it really, and I know it's so hard, right, with the time constraints to get into all of this, but asking about previous experiences with physical activity is sometimes a great place to start because you might find out, and often, and many of the patients we've interviewed have said, yeah, I was a triathlete. Or I was all-star, all pro in high school sports and played in college, and all of a sudden you're like, and I'm telling you to just go out and start taking a walk. It's almost like your patient's walking away going, they don't know anything about me, right? They don't know who I am. And again, I know it's hard. There are a lot of things on there that can be tough, but that can be a really interesting thing to learn something about your patient that is relevant door opening conversation, even from the nutrition standpoint, and the other pillars and how they come in and how you talk to them. But reviewing potential orthopedic limitations, if your time permits or you feel, I think this is one that's tough. There are patients out there that I will say that more and more we're finding that they could benefit from some rehabilitation in the pipeline of referral first. But I think that that's where if you're asking questions about their fears or their concerns or they express those things to you, don't discount that referral to physical therapy. We've actually seen quite a few patients take that up, and that may help with some of that self-efficacy for movement. It may be that pain is their rate limiter. And all the MSK programs in the world that are out there, we've had really interesting conversations about this recently, is that, they're very generic, they're very general. Sometimes that personalized rehabilitation may be a really nice starting point, going forward. And I think our other recommendations, that were on that poll and thinking about them are, ways that you can go, directions that you can take, but mostly let's get away from giving guidelines and let's not assume that they have to lose weight first. But I will say that for some patients, it may be that losing a little bit of weight might be the thing that does help them to engage in physical activity. Right now, patients are reporting to us that they feel as though if they could lose some weight, they might be more inclined to move forward with physical activity. So again, I think it's about asking the right questions to your patients for where they want to begin and encourage that they move towards physical activity.
Yeah. Thank you. Awesome. I'm going to launch the second question here. Give it 10 more seconds here. The end poll, and I'll share those results.
So happy you all answered this way. Thanks. Yeah, let's get away from that word preserve. We're researching it now. Genuinely, we have a clinical trial we have a pilot right now where we're actually measuring muscle mass with a randomized controlled trial, supervised, very similar to the one that I showed to you, but without the combined training that is control versus aerobic versus resistance with tirzepatide currently, to really understand what the contribution will be. It's great in theory. I just genuinely think in the hypocaloric state, it's going to be hard pressed. And again, I don't think we need to, right? We want our patients to have health, muscle health, feel and function their best. Let's frame it that way.
Fantastic. Thank you. We have one last question here for everyone. So I'm going to hit launch here.
I know this is like behavior 101, right? But it's hard to frame. Relevance is important to our patients.
I'll give another 30 seconds. Right. I'm going to go ahead and hit end poll so we can kind of review what questions everyone submitted here. Seeing the details, I think. Yep,
I can't see. Yeah, they're not coming up on our end.
they're not. Okay. Let me see here. Um,
While you're trying to find that out, I'll say that this isn't easy. And I put it up here because I was actually curious to hear how some of you might approach this. Um, I say this because it goes back to that key point of how do we help our patients develop a healthy relationship with physical activity? And if we can find something that's relevant to them about moving their body more, not for energy expenditure, but because of those independent benefits, we really see patients developing just a better long-term relationship in general with it. So it's quite interesting to think about how you go about doing that.
it is not pulling up for me. So that's a new, I apologize. I don't know how to, oh, download results. Maybe I can do that.
Nice.
Here we go.
They're making you work for it.
They are. Nope, that's not going either. Okay, sorry all. I did not intend on that. Um, okay. Oh, stop sharing. Okay. So we do want to open it up. If we want to go to the last slide, it just, or the, not the last slide, the next slide, it says just questions. So while everyone's kind of thinking questions, again, use that raise your hand feature, um, chime into the chat. We do have one here from Courtney. Are there handouts we can give our patients in regards to full body easy workouts with pictures on them? She says, I found some posters on Amazon, one with weight resistance bands, one with dumbbells, and one with body weight, but I don't know if there's any PDF handouts for patients. So just curious if you have a direction for maybe anyone.
Oh, Courtney, my dream. That's my dream is to build this program for all of you that you can tap into, right? That's a healthy environment for our patients from a remote standpoint, for an in-person standpoint. I think the thing that's really hard about it right now is we learned this from physical therapy, unfortunately. When we give someone a handout, it's short-lived. And it's not even in a moment of rehabilitation, the uptake and the adherence to it is usually at about 27%. Isn't that scary? So we do find that video media is a better standpoint point to kind of go forward. So one of the things that I've been recommending to a lot of folks is QR codes in your clinics to videos that you've vetted, even if they're on YouTube, that they're free and accessible for patients, where they show modifications, exercising in a chair potentially. We think about that always for our older adults, but the reality is when you're resistance training, having the support of a chair actually helps you isolate muscles in a really safe way. I love resistance bands at home. They're very safe and effective, and there's actually a lot of really good content out there that you can tap into. But my goodness, I would love to be able to offer really great tools before my career is over. It's on my list.
Yay. Thank you. We do have another question here. Do you have suggestions for children with special needs like autism?
Yeah, no, that's such a great question. One of my colleagues here at KUMC, Lauren Tomey, does amazing work with children with intellectual disabilities and autism. I will say that there are groups through American College of Sports Medicine that have certification where they are training credentialed exercise professionals in autism specifically. And that program is growing across the country. The leader of that's David Geslak. It's called Autism Connection, is the work that they do. And it's a really great program to look into so that if you need to refer, yes, this is a very nuanced population in terms of physical activity. The way a person with autism learns physical activity patterns is extraordinarily different from a gym. And we know that gyms can be very difficult places for them to be. So I would encourage you to check out Exercise Connection, check out the ACSM autism pieces of information that are out there, and so that you can connect with exercise professionals that have the credential.
Fantastic. We have a question here from Harris.
Mm.
It- um, they said thank you for that. Is it better to prescribe physical activity or to generally motivate and make our patient move? How can we evaluate the progress of our patient?
Yeah. I feel for all of you knowing all the things that you have to discuss in sometimes your appointments, that this is where referrals are really important. And I think referring to that qualified exercise professional that you trust and you know is not going to come at it from a bias and promote stigma in our patients, weight-related stigma, is extraordinarily important. I think that a lot of times the timing of you being able to give a prescription sometimes turns into, and I will get in trouble with the American College of Sports Medicine, even though I'm a fellow in saying this, but the Exercise is Medicine initiative of writing a prescription for exercise and giving it to your patient, while well intended, does feel like a very much blanket, like, here you go figure it out on your own kind of feeling, or you need to do these things. And unfortunately, in this space and in the data that I found, I find a lot of patients come back defeated and then want to avoid you because they didn't do it. They needed more support. So this is where I think your power comes in, making the good referral, getting them to a person that you know is going to be able to track that progress and communicate it back to you in a way that works. How can you work with them to get reports or share that data with patients? I know you don't want to be scoping through it all, but how can you create that relationship where you're working together is really important. We are working on a new, coming down, hopefully in September, it'll be available with the American College of Sports Medicine. I'm developing an obesity certificate for fitness professionals that we were hopefully going to have a network to help you all find qualified professionals to refer to.
That's amazing. Yay. It says thank you. That's great. I do have one more question here. What do
Yeah.
you think? Oh, we're getting two. All good. This is great convo. I love it. What do you think about the prescription acronym FITTE?
Okay, I don't know what the E is. You got to tell me what the E is. I know frequency, intensity, time, and type is typically what we think about in the standard guidelines right now for exercise. Enjoyment. Oh, that makes me so happy, actually. I was going to say, I don't like the fit principle by itself because it feels like an overlay. You need that personalized piece of asking patients what they like and don't like. Many of them will tell you that they don't know, but that's where the piece of you saying the words, I can tell you 100 things you can do, but if you don't enjoy it, I know you're not going to do it, really goes a long way. And I will say promoting enjoyment sometimes over anything else can be something really important because that's what's going to promote consistency and a positive pattern of engagement rather than something they feel like they should do or have to do. Physical activity needs to serve your patient. Your patient's not at, the hands of the physical activity program. We've got to flip their thinking. So I love enjoyment. Thank you for that.
Um, a comment from Courtney here about what you just said. I like to tell them something is better than nothing and consistency over perfection.
Absolutely. I always say, even our clinical trials, it's progress over perfection. Every day is different, and we need that radical acceptance of understanding that our day is going to dictate. But if we've made progress over the course of the week and done something positive, we've done something positive.
I love that. We have one more here from Jessica. She says, in regards to lean muscle and newer medications, such as semaglutide or tirzepatide, how do you personally address proper hydration? What indicator do you use to let those on those medications or overall know that they're properly hydrated? She says, I use the urine clarity with caveats, just depending on the person. So,
Yeah. It's such a great question. And I got to be honest with you, I've worked with our dietitians on this. I've talked to so many dietitians about this. And urine clarity is really and truly a big place that we're going with it. Although I will say that there's so much prescription of, in addition, we're seeing more and more patients that are taking additional supplements that they're getting online, and all these other things are totally bogging that relationship up. We know what's happening, right? Of all the things that they're hearing that they should be taking while on a GLP-1. So I think that, yes, the caveats are there. We've really focused on getting them on some kind of hydration tracker, whether it's through an online app. There's simple ones where they can track, and we're going with the basic. I know this isn't perfect, but 64 rule, at least 64 ounces of water, primarily water, is a base point, because we are seeing that in our exercise studies, patients are coming in super dehydrated, super, and it's impacting their ability to do work, to do the exercise that we actually want them to do.
I know I have an app and it just dings me every 30 minutes. Take a drink of
Oh,
water. And,
yep.
I get
And our
that
patients
reminder.
they're not thirsty. So they need that external reminder, is a really great behavioral way to get them to really, be thinking about it. That's so great. Even setting a calendar reminder, anything we can get them to do to be prompted, not only to eat, now we're seeing that, but to drink.
Wonderful questions. Yay. Well, we have still a few more minutes. We'll run through our case, have a little bit of discussion there. Raina, if you want to go ahead and pull the slides back up again. Um, I do. Someone asked here in the chat if, because there's so many beautiful QR codes and great information. Yes, we will share this afterwards, so that um, you can access that as well. So we do like to make recommendations of, again, where you can continue this learning. So our Obesity Pillars OMA Open Access Journal, here's some great articles, clinical practice statements, all these so that they can help just continue that journey of learning. As well as on the next slide, we have our OMA Academy. These are, again, just additional courses where you can get AMA PRA Category 1 credit. And so you're welcome to go check these out as well. And those links there are live. So when this is shared with you, then you can go to those links and continue to look. So we did have a patient case here submitted by, oh, go ahead. There we are, to Rochelle, by Rochelle Corrado. She is not here today, but we'll go ahead and go on to the next here. And perfect. So what we have here is a 21-year-old white female, 5'4", 180, BMI of a 30.9. You can see there her heart rate 77, blood pressure 115 over 78. They did lab results there. So we'll leave that up here for a sec, just so you can all take that in. Um, and then Raina, go ahead and go to the next slide. So here's the working diagnosis: obesity, ADHD, bed, chronic insomnia, hypothyroidism, Hashimoto's. Um, ADHD since age 12, has always had weight struggles their whole life, but really worsened in their teenage years. Normal sleep studies, chronic insomnia with delayed sleep latency. And you can see the current medications there at the bottom. And we'll go to the next slide. I will let you all read here so you don't have me in your ear, but what's been tried and the relevant past history. We'll give you a minute for that. Perfect. Hopefully you've gotten kind of the feel of this patient here. So the question that was submitted is on the next slide, Raina. What is an optimal treatment plan for a patient with obesity and binge eating disorder? Um, that is what this clinician is looking for help with. Um, so, Rena, if you can take down the slides and we can always pull them back up if someone needs. But gosh, I would love to hear. I'm taking notes here so we can pass along all your recommendations. But what do we got? What has anyone had a patient like this before? No one's had this patient before. Okay. Is there certain, oh, can you put the slide of the patient details again? Absolutely, we can put that back up. Um, is this the right slide you were looking for? Okay. Courtney here does have a comment that says definitely Zepbound to help with food noise and portion control. Is the patient responding to Zepbound? Um, that I don't know, but they are on it at the 5 milligram dosing. But I will ask that question if they're responding well to it. Renee, do you have any thoughts on a patient like this, or how you might,
Yeah.
um, yeah.
It's interesting, and I'll speak specifically to physical activity. So we want to still provide this patient with comprehensive care. And, one of the pillars would tell us, right, physical activity should be a part of that. And I will say to you honestly, there is not a lot of good data or clinical trials that have been done to demonstrate the relationship between physical activity being, beneficial for binge eating disorder. So that's an area that's been understudied in general. And I think we all know this. There's been one small study, 2020 came out that showed that there was actually a reduction in episodes with physical activity. But I there's no real general guidelines around it. And I think that this is where some of what we talked about related to how you frame it. If it's about caloric expenditure, if it's about that, we're really getting ourselves, potentially in the disordered eating space, we want to try to avoid that conversation, right? So where the healthy relationship with physical activity may matter could be with this patient. What are the individualized relevant reasons that we talk about how activity will help them feel and function their best? I think is a really positive way to go about the conversation. And we really want to avoid the discussion of the energy expenditure and the calories that are burned. I think it's best practice in that case. The one thing about this as well that I would point out to all of you is ADHD as well with this patient, since this has been a long time diagnosis. We do see that many patients with ADHD have reported that the gym environment can be very overstimulating, or it can also be a place where they feel overwhelmed. So again, before you give that blanket recommendation of just start going to the gym because you read somewhere that there could be mental health benefits from exercising, we need to recognize that unless the environment aligns with what the human's ready for, that could actually lead them down an opposite direction. So just some considerations.
I really love that observation about the ADHD and the overwhelming gym. That's
Home might be
fantastic.
a really great place to start for them.
Yeah. Jessica here has, oh yeah, we have multiple comments actually about this. Is she getting mental health support for the binge eating disorder? And Jessica comments, it'd be good to gather a more comprehensive idea of that relationship the person has with food in general. And I think that partially is what Renee was saying too, is just how do they think about food and thinking about it from a energy expenditure, avoiding that piece, but really how do we get our feeling our best. So I think those are really good observations. And Courtney here says, important to make sure they aren't doing any restriction type diets because it can worsen the binges. And I just tell them not to restrict food groups specifically because it establishes an unhealthy relationship. Agreed. Go ahead, Peter.
So in the next slide, did it suggest she lost 20 pounds? Am I making that up?
Go ahead to the next one, Raina. I
Right. So
did.
she's,
They started
yeah, right.
Zepbound.
So one of the things
Yeah.
I would look at with this patient is, does she need as much Vyvanse? Because that dose she takes is pretty high, with regard to side effects. So, is there a balance between the dose of the Zepbound and the dose of Vyvanse that would provide optimal benefits, but minimizing the side effects? Because she went from 180, it sounds like, to 160, which is a pretty good response in 4 months.
Thank you. That's a good observation. Um, uh, Thank you, Peter. I appreciate that. Harris says here a multidisciplinary approach, CBT, nutrition counseling, pharmacotherapy, really to manage the ADHD and the binge eating disorder first, and then manage the patient with obesity second. And Jenny says, I'm wondering if asking about what brings her joy in life and tag movement onto what she enjoys might provide her some more supports. And thank you, Peter. Your lower dose might also help her sleep. I'll note that. Um, and I do see one last comment here. I have managed binge eating disorder with Prozac that helps with mental health improvement, which contributes to their motivation for lifestyle modification. That's a great suggestion as well. Thank you, everyone. I want to leave a moment here in case anyone has any last things they'd like to weigh in. But I appreciate all the help and thought and point and direction for this patient and clinician. All right, well, with 1 minute left, Raina, can you take us to the slide about how to get their credit? So it takes us roughly 2 business days to get your CME for this session posted on your OMA Academy account. And you can watch the short video for instructions on how to do that. Again, reach out to us at echo@obesitymedicine.org if you have questions or you're not seeing it loaded there for you. And the links there are active. So when you get the slide deck, I'll post it just after this. Use that to go get that. We do really appreciate post-session feedback. This helps us grow, be better, make sure we're bringing value to you. And so if you can click that iecho.org/feedback, that helps us really get what we're doing well and what we can continue to get better at. So we do hope each of you are open to submitting a case for us. So there is a link there for obesitymedicine.tfa forms, that whole thing. If you submit a case, you would be here and present it, and then you actually get credit to go take a 1 credit course on our OMA Academy on us. So you get some benefit out of it as well as the great suggestions of everyone here in attendance. And lastly, we have recordings of all of these echoes on our YouTube channel. So you'll find the link there in the chat. Um, I think that, oh, our last slide here, same time, same place on July 11th. So it'll be the second Friday of July. And I believe the topic next month is, um, let me look. It is going to be medications and AOMs. So we hope to see you there. Thank you all for attending today and have a great weekend.